name is Dr. Megan Piper. I'm a clinical psychologist and part of the University of Wisconsin Center for Tobacco Research and Intervention. And today, along with Kristen Berg, I'm going to be talking about addiction, treating a chronic disease. This is a special presentation we put together specifically for Women's Health Foundation First Breath program. So I hope this is going to hit a lot of the issues and concerns and questions you may have, and we will take some questions at the end. So first, what we're going to talk about today are primarily the two most common addictions, and that is alcohol and tobacco. At this point in the United States, about 18% of adults smoke, and that is down considerably from where we've been in the past. In fact, it's the lowest in the modern era. So that is really exciting to see. And we are still currently at more than half of adults drinking in the United States. So again, with those being the two most common addictions, the ones that people see and hear most about, and probably the ones that are most commonly presented to you in your practices, that's what we're going to focus on today. So first thing we're going to talk about is habit versus addiction. We're going to talk about the distinctions, how they're similar, but also how they're different. We're going to look at a scope of the problem, a little bit more detail about who's using tobacco, who's drinking, and both across the United States as well as in Wisconsin. And finally, we're going to get into the meat of the issue, screening and treatment. How do you look for, assess, identify patients that need treatment for tobacco and alcohol, and then what do you do with those patients, whether they're ready to quit at this point or not? And of course, a lot of these will be focused on pregnancy and dealing with women pregnant or just recently postpartum. So let's talk about habit versus addiction. Think in your head what kind of bad habits you have. What are some things that you do that you really wish you didn't do? Or maybe these are things you did when you were younger, but you don't do them anymore. You know, who bit their nails when they were growing up? Or who was a knuckle cracker? Has anybody ever been a nose picker? That's not something you probably want to admit to the person sitting next to you, but we've all had bad habits. Procrastination, I would be guilty of that one. Overspending, that sort of thing. Now these are habits and things that you do on a regular basis, and we'll talk about how a bad habit, something that's maybe inappropriate or not so socially acceptable, is different from an addiction. Because when we're talking about addictions, we're talking about using substances like alcohol, tobacco, caffeine, other drugs of abuse, cocaine, heroin, meth, gambling, sex, exercise, and how important it is to think about when you're treating a woman who's coming in to see you for an addiction for tobacco or alcohol, how that's different than just a bad habit that she should be able to stop. So the first thing we're going to talk about is something called automaticity. This is this idea that you can just do something on autopilot without thinking about it. The example I give for smokers is sometimes they smoke a cigarette, they're smoking a cigarette, and they go on and they light a cigarette. They already have one burning in the ashtray. They weren't even thinking about it, they just did it. One that might be familiar to you is you're really busy from a day of work and you're driving home, and you realize you're halfway there and you don't remember making any conscious decisions to turn or change lanes or do whatever it is you do because you're just on autopilot. So when you're engaged in something automatic like that, you actually have to bring that behavior into conscious awareness to be able to change it. Because if you're on autopilot, you can't change. You've got to be very aware of all the decisions you're making. And that is something both habit and addiction have in common. A lot of people talk about, I was a nail biter and I stopped, but then it got real stressful and all of a sudden I look down and I have no nails because you did it on autopilot. You have to be aware. A lot of times, again, drinkers will say, I finished that fifth before I was even aware that I had taken more than one drink. Another issue to think about when we think about habit versus addiction is something called positive reinforcement. That's the buzz you get, the good feelings that you get. And what this comes from is Thorndike's law of effect, is the psychological term for it. What it means is if it feels good, you're going to do it more, right? If we enjoy something, we want to do more and more of it. And that's true of a habit. A habit can be enjoyable. Sometimes people like the feeling of cracking their knuckles. That feels like a good release. But addiction is much, much more enjoyable. The positive reinforcement, the buzz, the good feelings you get from an addiction are much greater. Because what happens is when you use an addictive substance of any nature, it actually produces a dopamine surge in your brain. Okay, so your brain actually has this reaction that is pleasurable. And there's a whole part of your brain whose whole job is to regulate pleasure. And when the dopamine gets in there, it really makes things feel good. Now, with addictive substances, one of the issues is how quickly it gets to your brain. Nicotine gets to your brain in 6 seconds and starts the buzz in 6 seconds. That's what makes nicotine so incredibly addictive. If you think about the difference between cocaine when it's snorted, right? That was an addictive problem. And then, what was it, late 80s, we had the onset of crack, and that's inhaled. And crack became so much more addictive. It's more addictive because it's inhaled and gets to the brain faster than things that are snorted. So in this respect, nicotine getting to your brain in 6 seconds becomes incredibly addictive. And what happens when it's in your brain, when nicotine is bathing your brain actually changes. You get something called neural adaptation. So if these little green guys are nicotine receptors and the holes are just waiting, what happens is, when there's more nicotine, they grow more receptors. Your brain says, oh, I have this much nicotine all the time, I probably need more receptors in there. So all of a sudden you have so many more green receptors to be occupied by the red nicotine molecules. So this happens for nicotine receptors, and it also happens for the dopamine receptors in your brain. So that means that now, when something pleasurable happens, like let's say you see a cute baby or you see a puppy, there's dopamine in your brain, but all of a sudden, is there really enough dopamine to occupy all of these different receptors? And if there's not, that could be a problem. All of a sudden, the things that used to be rewarding and pleasurable might not feel as pleasurable as they used to. And because you get neural adaptation, because your brain actually changes, you get something called tolerance. Tolerance is defined 2 different ways. One is that you need to use more of the drug in order to feel the effects. So that would be something along the lines of when you first started drinking alcohol, perhaps. It only took 1 drink for you to feel a little bit of a buzz. And if you drink on a more regular basis, it now takes more drinks for you to feel that kind of buzz. The other definition is that you can use more of it without getting sick. The tobacco example is perfect here, right? The first time somebody smokes a cigarette, many times they feel nauseous, they may vomit, but over time they stop having that reaction and they just start feeling the other effects of the tobacco. Now when it comes to habit, we don't develop tolerance. There's no tolerance developed in your fingernails unless your fingernails just get weaker as you bite them. There's no tolerance developed in your knuckles or when you pick your nose. You can still do that at the same rate, same experience. But with addiction, this is definitely holds. You need more and more of the drug over time to feel the effects, and you don't feel the negative effects in terms of initial use, like you don't get nauseated when you smoke. Again, because you have this neural adaptation, because your brain has changed in the course of this addiction, and you've developed tolerance, you have withdrawal. Your brain notices when there's not enough drug on board, and it says, hey, we need more, our brain needs more, and it will invoke different symptoms. It will invoke craving, it will invoke negative affect, it will invoke irritability, it will invoke difficulty concentrating on anything except obtaining the addictive substance, okay? And that is withdrawal. And it can even be something, not just falling levels in the brain, but if you're in situations where you usually use and you're not using there, even, let's say I smoked a cigarette before I went bowling, and then I go into the bowling alley, and I used to always smoke with my bowling buddies, I can have cravings and withdrawal there just because that's the environment that I'm in, okay? Or let's say I'm out with friends, and I had a cigarette before I went out, but now I'm out with my friends, and they're all smoking, and that makes me want to smoke because I'm used to doing that ritual, and that is part of the addiction, and I have withdrawal symptoms. So when you think about tobacco withdrawal, craving is huge. Negative affect, loss of concentration, difficulty sleeping, hunger, those are all withdrawal symptoms. And sometimes people will say, well, really? With tobacco withdrawal, it's not that big a deal, right? Especially compared to alcohol withdrawal, which can be life-threatening. But we talk about sometimes people feeling like they've lost their best friend. It's almost like they're in mourning. They've given up the one thing that's been with them through all of their hard times, their divorce, their marriage, their graduation, their loss of their job. It is reliable and it's always there. And it can have huge consequences. The cravings can be climbing the wall types of cravings, the likes of which you would expect to see in a heroin addiction can happen. With respect to negative affect, I talk about irritability a lot with people. I worked with one woman an older woman, and she was a great knitter, and she came in a week after her quit date, and she was very upset because she'd been talking to her sister on the phone, and she'd gotten upset with her sister, and she'd hung up and put her phone through the wall. So it's not just I'm a little touchy, it can be incredible irritation. So it's important to treat that. It's important to treat withdrawal for both tobacco and then also for alcohol. Alcohol withdrawal looks very similar. You get craving, you get anxiety, you can have seizures, delirium tremens, and again, it can be life-threatening and may need to be medically managed, so that's something that you need to think about. But when you're helping somebody get off either of these substances, withdrawal is a necessary component that you'll need to address. And again, you don't have withdrawal from habit, not so much. You don't have a physiological reaction to not having it, but you certainly do with addiction. Negative reinforcement. This is another place where we can look at habit versus addiction. Negative reinforcement is something that makes you feel better when you're feeling bad. Now, you can feel bad for lots of reasons, right? You can feel bad because you just had a fight with your best friend, or you can feel bad because you don't have enough drug in your system, and it's a withdrawal-related bad feeling. Either way, when you use drug, you can feel better, okay? And that can be very reinforcing. In fact, a lot of models of addiction talk about the negative reinforcement model. People don't have enough drug, or they're not using drug in a place where they usually do, makes them feel bad, makes them crave, and then they use drug and feel better. And that's how the cycle sort of perpetuates itself. Now, habit can also make you feel better if you feel bad, right? If that's your coping response when you're tense or anxious, maybe before the talk I was sitting back there going like this, chewing on my fingernails because I was nervous, and it might have helped me calm down as a coping response. But I'm certainly not feeling bad if I can't chew my fingernails. Loss of control. This is probably the biggest difference that I really hope people get out of this talk today. And that is the idea that with habit, it's not that you've lost control. If somebody pointed out to you that you were chewing your fingernails, you could probably stop, right? If somebody pointed out that you were smoking a cigarette or drinking too much, it's not likely you can stop without help, okay? When things feel like they've lost control, and most smokers will tell you they know they've lost control. They know it's bad for their health, and they do it anyway. And why? Because they've lost control over the addiction. With drinking, it's a little bit different. With drinking, sometimes part of the treatment is to get them to acknowledge that they've lost control. Oh, you tried to have just one drink, and you keep ending up having, the entire six-pack or the entire bottle. That's a loss of control, and it takes some people a while to understand that they've lost control. Because then, once they understand that they don't have the control, then they really are identifying as being an addict. Addicted to tobacco, addicted to alcohol, whatever. But the idea is when you continue to use when you don't want to, that illustrates the loss of control. So again, when we think about habit versus addiction, habit and addiction, they're both automatic. They're both things you can do without thinking about it. There's some positive reinforcement, right? For sure you get a buzz from the addiction substances. Habit can feel good, can feel stress relieving. And that also is consistent with some negative reinforcement, right? If you're feeling bad, maybe that's something that makes you feel better. But when it comes to addiction, we have actual tolerance. We have physiological changes in the brain and the body that allow you to use more of the substance. We have withdrawal. When you don't use the substance, your body reacts to that, and it does what it needs to try to get you to get back into using the addictive substance. And that means you've lost control, because your body is telling you, I need a cigarette now, and in many times, without help and support, you do have no control over that. And so what we want to talk about is how you are going to be treating addiction. I know it doesn't seem like tobacco, it's a legal substance. If you're over 18, you can get it. It's highly, highly addictive. And it will kill you. It is the only legal substance that when used as directed will kill more than half of the people who use it. So what we've got as we think about this as a true addiction is this is the diagnostic criteria. Okay, so DSM-5 revised the diagnostic criteria. They used to have substance abuse and dependence, and now they just have substance use disorder. The first part is impaired control, which we talked about, right? When you have that loss of control. It's taking a substance in larger amounts or over longer periods of time. It's a persistent desire to cut down our use, but you can't seem to do it. You spend a lot of time obtaining, using, and recovering from the substance more than you had anticipated. This tends to become more of an issue for alcohol than it does for tobacco. And craving at any time, especially when there are environmental cues, and we talked about how important that can be. Social impairment. Failure to fulfill major obligations at work, school, or home. Again, this is less of an issue for tobacco because it's non-intoxicating and because you can use it just about anywhere. But certainly for alcohol, when you notice that people aren't, perhaps women aren't able to get to work, or they're late for work a lot, or their kids are late for school, those kinds of things that just don't seem to be done because they're either using or they're recovering from using. Substance use that continues despite social problems. So people are commenting, maybe, why are you always stepping out at the bar to go have a cigarette? We're all in here hanging out, and you keep leaving the group. You're not fitting in as well. And then other things that are given up in order to use substances. Risky use, recurrent use in physically hazardous situations, despite physical problems. Now, recurrent use in hazardous situations more likely to be an alcohol issue for sure, but continued use despite physical or psychological problems, every smoker knows it will kill them. Every single smoker, whether they've rationalized it or said, not me, or my grandma Minnie used to smoke and drink every day until she was 95 when she was hit by a bus. Everybody has their stories, but they know it will kill them. Alcohol, not quite as much. Alcohol, you're usually dealing with either somebody has an alcohol-related disease, or if she's pregnant and she's continuing to use, knowing the damage it can be doing to the fetus as well as to her health, then you've got somebody that's in a risky use criteria. Pharmacologic criteria, we talked about tolerance and withdrawal. Both of those can be present. So what they do, instead of separating abuse and dependence now, is they just use severity. So if you have 2 or 3 of the symptoms we just reviewed, that'd be mild, 4 to 5 would be moderate, 6 or more would be severe. But what I would also reinforce is that anybody that comes to you and says, I smoke and I don't want to, and I drink and I don't want to, I don't care how severe it is, they're asking for your help. And for the most part, women who know that it's bad for their baby and are still doing those behaviors really do have an addiction they can't stop without your help. So in terms of the scope of the problem, again, like I said, we're looking at about 18% of adults in the United States smoking as of 2012. Those are the 2012 numbers. A little bit more than women smoke. We still have about 12% of pregnant women smoking, but the highest group really are people with mental illness. And so that's something else to be thinking about. How is mental illness combining with tobacco and alcohol use in your patients to make things really hard for them to be as healthy as they want to be? And how can you work to help that? If you think about Wisconsin, actually we have a little bit higher smoking rates. We're at about 20%. The gender difference is a little smaller between men and women. 13% of pregnant women are smoking at this point. We have about 40% of people who are ever diagnosed with depression are smoking. And of course, socioeconomic status is a big predictor of smoking. People in lower socioeconomic status are much more likely to be smoking. We're talking 33% versus 20% of the general population. So again, that's another issue. When your clients come to you, these are women who may have mental health issues. They obviously are lower socioeconomic status and are needing extra help. And so this is a group we really have to work hard to get them the treatment that they need and the support that they need so that they can beat the addiction. And there are also racial differences and ethnic differences that we have here in Wisconsin in terms of smoking. When it comes to drinking, remember I said earlier that a little over half of the adults in the United States drink. Here in Wisconsin it's 66%. We've made it all the way up to 2/3. We have the highest binge drinking rate in the United States, so 22% of adults binge drink. By definition, that's 5 or more cigarettes for men, or 5 or more drinks at a sitting for men, and 4 or more for women, taking into account body mass. About 6% of Wisconsin drinkers are heavy drinkers, and that means for men they're drinking 2 or more drinks a day. For women, they're drinking 1 or more drinks every single day. And at this point, about 9% of pregnant women are reporting alcohol use in the last 3 months of pregnancy. So again, binge drinking is probably the most common form of problem drinking that we see. It's more common when in the younger age group, and it's also, interestingly, more common in higher socioeconomic status. What's common in the lower socioeconomic status is that they do it more frequently. Fewer people are doing it, but when they do binge drink, they're binge drinking more frequently, and they're drinking a lot more than 5 or 4 drinks per day. Okay, so that's the thing that you want to be thinking about. The women that are coming to see you, is she binge drinking? Is she having more than 4 a day? And is she doing it a lot? And are you seeing a lot more than 4? Is she, drinking an entire bottle of wine, which would be 4 or 5 glasses, or an entire fifth, or, however much beer? So, like I said, we're talking about addiction here today, not habit. We're talking about something that is disproportionately affecting women of low socioeconomic status, women who are not white, women with mental health issues, and so addiction, being very different from habit, is definitely something that needs treatment from providers such as yourselves. So with that, I'm going to turn it over to Kristen Berg, who's an internal medicine physician at the University of Wisconsin, and she also works at the Center for Tobacco Research and Intervention, and she's going to talk about treating addiction.
Thank you. Okay, hi everybody. Thank you very much, Dr. Piper, for that excellent background. And I think now that we have that frame of reference for just the differences between addiction and habit, we'll talk a little bit about treating addiction and the effect that you guys can have on your patients. So, treating addiction is really hard. Without assistance, as far as smokers go, only 3 to 7% of smokers who attempt to quit smoking will be successful at the 1-year mark. So that's really low numbers, but with optimal treatment, that number will improve 4 to 10-fold to about 30% of smokers who get that optimal treatment, and I'll tell you what that is, being able to remain smoke-free at that year point. Similar numbers with trying to quit alcohol use and quitting drinking. With optimal therapy, you're getting numbers in the 40 to almost 50% range that people can help their addiction and change their life. So for the next part of the talk, I'm going to go through tobacco treatment and alcohol treatment separately. And I'm going to be using the 5 A's framework, which are a little bit different for both of these substances, but they give a really nice evidence-based framework to go through. So the 5 A's for tobacco treatment are ask, advise, assess, assist, and arrange. So as far as asking about tobacco use, you're asking every patient, every visit. Healthcare organizations are encouraged to use this as a vital sign. So along with your blood pressure, your heart rate, your temperature, what's your tobacco use status? Are you a current user? Have you quit? Or a never user? When you're advising patients who are using tobacco or who have quit, you want to be using clear, strong, personalized advice to quit. That personalized piece is really important. There's been a lot of evidence that shows that really puts it in the context of the patient's situation and really helps them incorporate that advice that you're giving them. So statements like quitting smoking is the best thing that you can do for your chronic bronchitis just really helps to kind of make that advice a home run. And we know that this works. Brief advice from physicians increases the odds of quitting, and in pregnant patients, early smoking cessation advice will increase the odds of that woman quitting or cutting down her cigarette use by more than 50%. So just a huge impact that you can have just by assessing and advising your patients. As far as the 3rd A, the assess, you're asking if they're ready to make a quit attempt. And this is kind of daunting, how do I bring this up? How do I ask, are you ready to make a quit attempt? So some of the things that Dr. Piper and I like to use are you interested in making a quit attempt today? How do you feel about trying to quit? Or would you be willing to talk about different treatments for quitting? And this really kind of puts the ball in the patient's court. It lets them know that they're in control of the conversation, of the situation. You're not demanding that they quit smoking. You're not being demeaning towards their smoking. You're opening the door for that conversation to happen.